Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
Welcome to this section on thyroid cancer. It's exciting to be able to speak about advances in thyroid cancer. We haven't had any in a while, but I want to start with the basics of what happens at diagnosis. So Dr. Patel, you've been sent a patient by the endocrinologist who said, this is a person with metastatic thyroid cancer. They've given the patient all the radioactive iodine they can get, right? Because that's going to be our preferred treatment. And they've been declared iodine refractory. And they're sent to you. What do you think about in clinic for thinking about how to treat this patient?
Yeah, thanks, Jared, for that question. I think there's a couple of really important considerations. One with thyroid cancer is the pace of the disease, how quickly their disease is growing even after they are iodine refractory, whether they're symptomatic from that metastatic disease in any way. I think those are some of the first considerations, because sometimes there may be a window of actually observing patients safely and making sure that they are adequately suppressed in terms of their thyroid axis with the appropriate dose of Synthroid, so their TSH is in an appropriate range. I think those are some of the initial considerations. But then,
if I could just pause you there one sec. So just to clarify, everyone, you could think of this like your thermostat at home, right? Imagine your goal was to have the heat kick off, right? And how could you accomplish this? Well, one way could be you put space heaters all around your house so that your house is so hot that the thermostat doesn't kick on. And in this case, the reason you would want to do that is that the heat is a chemical called TSH, which in addition to causing the thyroid to make thyroid hormone, also makes the thyroid cancer cells grow. And so what you do is you're giving a dose of levothyroxine, otherwise known as Synthroid, that is so high that it kicks the thermostat off. And yes, you can have side effects from this. In particular, people with AFib, it's something to be cautious about. That's a cardiac abnormality. But usually, while people can be a little symptomatic from this, it's trivial compared to the side effects of what the drugs that we're about to talk about can do. And in my practice, I've had people go years, in one case, even a decade, getting my favorite chemo drug. Sid knows I've used this joke way too long because a million years ago, he was my fellow. No chemo at all, right? Nothing has fewer risks of side effects than nothing. But when that's no longer possible, Dr. Patel, you've observed them and it's growing. What other info? What comes next?
Yeah, so they're after patients have had growth or symptomatic disease, then doing molecular profiling of their thyroid cancer is one of the critical things in deciding what therapies to choose. Because as Dr. Weiss mentioned, we have several agents that we have available for thyroid cancer. Some of them are very broad. They target a lot of pathways, but we've learned over the years that certain thyroid cancers have genetic changes in them that cause them to grow. And if we can really identify what that is in any given patient, we can hopefully personalize their treatment with agents that are a little bit more selective and hopefully more tolerable. So that usually includes broad molecular profiling, because some of the genetic changes we see in thyroid cancer are point mutations, so single changes like BRAF, V600, but some of them are larger changes where two different genes that are not typically connected are connected together, so like RET fusions. And in those cases, doing profiling both with DNA analysis as well as RNA analysis, which is the downstream messenger, can be helpful in identifying these fusions. And so that's something that we commonly do for our thyroid cancer patients before selecting for oral targeted therapies, which we have several now. We have these broad agents like lenvatinib, which targets multiple tyrosine kinase, but other more selective agents such as selpercatinib or palsetinib, which target a fusion called RET and can be more selected to those specific genetic changes, as well as more targeted agents for BRAF, such as dabrafenib and trametinib, which are for that BRAF mutation specifically. So that broad profiling is really critical in making sure we get that before we select therapies for patients.
And I don't want to go too far in the weeds, But the type of testing does actually matter here. So apologies, I'm going to take just a little step into the weeds. There are a lot of these changes. There are others like ALK, NTRK, Energy1, and MET that we occasionally find. And so what is good testing? Good testing needs to be broad enough that it tests for all the good stuff, but sensitive enough that it actually finds it if it's there. Because in the case of some of these combined genes that are really big, or some of them where you don't always know the partner that it's combining with, if the testing doesn't include something called RNA sequencing, you can actually miss something that's there. And then you're ending up with much more toxic and less effective drugs than the really good stuff if you make that match. And so it's not just about checking the box for testing, but having the good stuff, meaning DNA and RNA next generation sequencing. And I'm sorry for going into the weeds, but these particular weeds just matter. So I think for the most part, with one caveat that's also the weeds, for the most part, we prefer if we can match target with targeted therapy to do that. There's a controversy with one particular target called BRAF, whether it's better to start with the targeted therapy or the more general. Unless either of you feel otherwise, I'm going to leave that to a discussion in the doctor's office for an individual patient. But our options here, right? We have, just to review, we have suppressing the TSH with levothyroxine and watching. We have targeted tyrosine kinase inhibitors. We have less targeted tyrosine kinase inhibitors. And we have one new option. I'm hearing silence. I can take one on the segment if so, there's a very new idea, and it's a little controversial. It's not quite established, so this is not an endorsement. You should run out and do this. But I think it is important for us to mention that there is a new option on the horizon that exists, that more of the data is being gathered on, and that one could at least talk to one's oncologist about. And that's resensitization to iodine. So at the beginning of the segment, it was mentioned that radioactive iodine is our preferred treatment. In earlier stages of the disease, we prefer it because it can be curative. And we like it because it gives the opportunity to give that favorite chemo, no chemo at all, for some amount of time. A new option that's come on the horizon is the recognition that these TKIs, in addition to controlling disease, can also convert some cancers that are not radioactive iodine sensitive to radioactive iodine sensitive cancers. And so this is useful in two potential ways. And again, this is not an endorsement to do it so much as putting the information out there that this is something you could talk to your oncologist about, which is either upfront, you can give a short duration of targeted therapy, repeat the radioactive iodine scan, and consider radioactive iodine, again, with the goal of doing nothing for a while. Or at the time that a cancer becomes refractory to the TKI, it's worth repeating that scan because you might be in a situation where you're out of standard options, and this can add an additional option to therapy. Dr. Patel, Dr. Sheth, is this something you're considering in your practice? Anything to add to this?
Yeah, I mean, I think it's something that the data is quite interesting, but there's still a lot we don't understand. What is the right agent to use? How long do we use it? When should we be testing with imaging afterwards? And so I think what we really need to, at least at our institution, figure out is just have buy-in from the whole multidisciplinary team about some of these questions and try to protocolize how we treat these patients and to really then better understand our results. And I think, so that's one. I think the second is, as we've talked about in other segments, is just how can we have more confirmatory data. So a lot of small phase 1, phase 2 trials, but we really need a bigger trial to see is this the right strategy or not.
Well, thank you for joining us for this segment on thyroid cancer.
Thank you again for joining us. This podcast was made possible by the generosity of our sponsors and you, our community. Please like and follow us on YouTube, Facebook, Twitter, LinkedIn, and Instagram. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.